Good evening, ladies and gentlemen. It's so good to have you all on this evening, Saturday, for a very special lecture and for a highly demanded lecture on the topic Complications and Solutions in Implant Dentistry. We hope you all have been doing well, safe, and are probably back to your practices. It's my pleasure to introduce our speaker, Dr. Souheil Hussaini. For the ones who don't know him, I'm sure most of you all by now know him, and the fact that he's the person who's going to help you with the special session on the topic Complications and Solutions in Implant Dentistry. So for the ones who don't know him, quickly, I'd like to introduce our dear speaker, Dr. Souheil Hussaini. Dr. Souheil completed his post-graduation in prosthodontics, TMD, and implant dentistry, concurrently with a Master of Science degree in oral biology from the University of Medicine and Dentistry, New Jersey Dental School, USA. His undergraduate degree and PhD was from Annamalai University, RM Dental College and Hospital, India. He is currently holding a part-time faculty position as an adjunct faculty at the Rogers Dental School, USA. His master's research and PhD was in the field of dental implants. His private dental office is based in Dubai, where he performs implant surgeries and prosthetic treatments. He is the founder of Implant Dentistry Study Consortium, the first ADA-approved dental implant continuing educational course in the Gulf and Middle East, which is also an affiliate of the Society of International Congress of Oral Implantologists, the ICOI, and the University of Toronto. He is the chairman of the Scientific Committee, Implant Dentistry Consensus, United Arab Emirates. Since the year 1997, his experience is exclusive in implant dentistry with most of his implant systems. He's presented lectures at the Harvard University, at the University of Toronto, at the Hunan University, and the Pennsylvania Penn University. He's organized several socio-economic activities and dental camps in Erbil, India, Yemen, Sudan, Bangladesh, and Sharjah Central Jail. He's published numerous articles in the International Journal of Prosthodontics, Implant Dentistry, and Journal of Prosthodontics. Once again, thank you for joining us, Dr. Souheil. I now request you to start with the presentation. Ladies and gentlemen, session 3 on the topic Complications and Solutions in Implant Dentistry.
I appreciate your presentation. Thank you very much. I'll just go on the last few slides of last week. If we look at implant dentistry as a building, which has 7 stories, and every story can be designed differently in your practices. However, each room and every story has an importance, and it has to be followed with skills, knowledge, and experience in every room, because each room has a value, and we should look at this whole picture of every step that we do, for whether it's a block graft, whether it's particulate graft, whether it's an open sinus lift, internal sinus lift, immediate extraction implant. All these rooms that we discuss, each one have to be clearly understood, and every step should be known, how you do every of that step. We discussed about if there's a suturing error, the concept of time is an issue when you are receiving a complaint from a patient. When was it happening? And it's very important to learn to appreciate the power of when. Same thing with the position of a wrongly placed implant, because if you know when this has happened, it makes a big decision making. And if you're strong in every department, you know, for example, in this scenario, this was not a placement problem. This was an osteotomy issue. And accordingly, you make a decision. Same thing with this case, you know, the bone was harder, so they broke the screw. We discussed about this. My point is, I'm just going back for the ones who, to refresh your memories. Finally, we've come up to this 7-story building, that each building is very important. And every room and every floor in this building has to be recognized at the early stage of implant therapy, because negligence to any step will compromise the case. And what are we doing in this program, this 1 year program? We are trying to identify the frequencies of the complications and the risk factors, and also how to avoid those complications. We discussed about this lady who just needed a cervical erosion filling, but she landed up receiving a dental implant and a root canal uh, and a new crown for no reason, because of the diagnosis was not well documented. Now we start today's session with an understanding of the difference between an event and a process. What we are suggesting to this class members, that we will take you from an event form of doing implants, that the patient comes, you place the implants, the patient goes. If they have a problem, they come back, they tell you the problem, and then you solve the problem. You make a decision, you're motivated for these people. You have a calendar today. Your receptionist has told you that we have an issue today. Mr. Jones has a pain on her implant and his implant, or Mrs. Jackson has broken a screw or something. You come to the calendar, you come to the appointment, you have a challenge to fix it, and you fix it and you go ahead. This is what is an event. However, what we are discussing is a process. A process, it's not, you don't make decisions on the spot. You develop a strategy that automatically will care for all the possible problems that can happen. It matures you and your patients to another level, that they're always being cared for, and it's consistent. You have a, it's not something that only happens based on the calendar and based on the your secretary informing you that today we have a complication. Consistently, you know how to deal with any problem that can happen, because there's a protocol. Of course, it has its challenges, but it changes people from being just solving that problem for the day, or you are always aware of the possible problems that could happen and you're prepared for it. And of course, it's more difficult to be a part of a process and part of an event. What are we mentioning here is, normally a patient comes, step one, you do the treatment. If they call that they have a complication, that becomes second step. You identify the solution for that complication, you solve it, the patient goes back to normal life. That's what normally happens in the uh, general protocol of most of us. And that's what we are suggesting to change. What we are suggesting to change is, we are predicting the complications before the treatment starts. How? Because we have a classification of complexity, where the articles that was sent to you last week, again, it will be sent again for the new ones who are part of the program. So we are classifying the complexity before we do the treatment. We are identifying the step in your unfollowed protocol, because we are following what happened, because we're documenting everything. So when a complication comes, we go back and see, because of that step was not followed, and that caused this complication, and accordingly we go back to the protocol and we update the steps, okay? And then we document and maintain the treatment, that patient. So we are emphasizing on predicting the complications and emphasizing on the maintenance of the treatment. We cannot let the patients go, at least not to be seen once a year. And the advertisement that we have Facebook, Facebook, and we have different social media, I have no problem with them. But my strategy is, beside those, we have our phone call to these patients and the WhatsApp if we need to inform them about a document or a picture or a video. So we are following with the patient face to face. It's not just the social media that they have to look at advertisements. So let us start the steps. So we are simplifying predicting complications in 3 steps. First, we have to write the steps of the procedure that we want to do. Any procedure we plan doing, we have to know every step in that procedure. And then we will learn how to classify the complexity of that procedure. Then we list the things that can go wrong. And then we use our inquiry skills for every step, how to look at the case from analytical point of view, which is inquiry skills. Now, what is writing the steps was already mentioned, and we can show it again. The complexity classification is a very simple classification that we will all learn from next week. And the reason for that is we all know that we need a universal language when it comes to complication. When it comes to even implant treatment, we need a universal language. If you look at the concept of universal language, we know the advantages of having a universal language. The same thing applies if we are going to treat patients and we're going to treat complications. So if we have a universal language and we are suggesting that for classifying complications, then it's much easier because of the advantages that the universal language has, how to deal with different treatment modalities. And again, I will ask Ruben to provide the articles that for the newcomers that by, for example, if you want to place a couple of implants for this patient, for you to communicate that to your staff, to your nurses, to the insurance, to the others, you will require a paragraph or a page or 2 pages to explain what you're going to do. Imagine, just imagine, by just writing this on the patient's file, and if this is the universal language of how we classified the scenario, how many implants on which side, and everything is inclusive. You just have to know this language for you to be able to inform whoever needs to be known, whether it's the other referring doctor or yourself or your staff. Just by simply putting few alphabets, you can have a universal language between you and yourself. I think the steps that we mentioned, when you look at them, you might say, wow, that's too many steps. What is going on? But if you look into the simplicity that is made, it reminds you of a driving test. I looked at a handbook of a driving um, for you to test yourself on driving. The book is 138 pages, how to drive on the street. I'm sure all of us, when we are driving, we don't read that book every day. We know how to drive, but we know if I don't put that gear on that thing without pressing the clutch, or if I don't do that, or if I miss that step, I will make an accident. So we are actually not saying that all these steps will be looked upon every time you do every step. Automatically, you will follow them the same way you drive. For example, you take a panoramic x-ray, you do intraoral examination, you do bone sounding, you take photographs, and you take impression. That's all you need to do on the first visit. Same thing when you're doing the surgery. All the steps are written. It's not that because we are writing all the steps, it becomes more difficult. It's the reverse. You just read them once, apply them a few times in order, and that's it. That's that's why it's easier to follow. Now I'm going to take you to an incident that happened last Wednesday. just to, because I'm here in Canada and my clinic is in Dubai, I can't go back. So I'm solving the complications of the clinic back in Dubai by consulting with my staff. Let's listen to this audio.
And as you suggested, I irrigated the area. There wasn't any object blocking that area, and in fact what was bothering him was the rim of implant itself, because the gum got a little bit receded in that area, and now he's feeling the sharp edges of implant itself. So I wanted to see, is there anything we can do, because already there is half a screw inside, we cannot place any healing, but you know, anything that we can fabricate maybe ourselves just to place on top of it, so he won't feel with his tongue the rim of implant. Kindly advise. Thank you.
So as you can see, there is a crown missing. There is a broken screw, which is much deeper than the normal space that should be there. Okay, that means one of our colleagues tried to remove the broken screw, but again, it's a complication. And on top of that, the patient is complaining now, the sharpness of the implant is bothering the patient. And if this gingiva was supposed to be 3 millimeter above the bone level, then this would have not happened. So we have two issues. We have a biological issue, which is bone resorption, and we have a mechanical issue. Now, for that, I think it's best if I take you through the case and let us see how this case started. And maybe that way we can understand why this methodology that we are suggesting is a better solution. Now let's look at some diagnosis photographs. Okay, this is 2015. Every photograph is documented. And we have, as we said, we have steps when the patient comes for diagnosis. We have diagnosis photographs. First, the patient takes a panoramic, and then we do the intraoral examination. And then we take photographs, and then we take an alginate impression. That's the 4 steps as we discussed. So we are documenting the steps for evaluating or for diagnosis. This is the area of concern. This is the opposite right side. This is the patient-centric occlusion maximum intercuspation. You can see the crossbite. All right. Let us look at some radiographs so you understand the problem. So the patient at the first point of time, I mean, at the first earliest complaint is on the right maxillary area. He has other issues which will be solved eventually, but the first thing, this bridge is bothering him, the food is trapping, there is a mobility, there is a smell. So this is the area of concern. And the treatment plan was to extract this teeth and to place 2 implants for this patient. As we said, we will follow the protocol. Every procedure has a folder. Every folder has a documentation, the time of the surgery, even room temperature, the date is already in the photographs. The extraction is done. We are trying to avoid preparing the bone in a way that might lead us to place the implant buccally. So expansions are used versus drilling. The implant is 3.7 by 13 is placed. And because of the buccal concavity, we are thinking maybe some bone augmentation is required. If you draw a line from the center of the tooth to the other side, you know we are on the functional cusp. We are not placing this buccally. And we're looking at the gingiva. We are placing the second implant because of the fact we don't have 7 millimeters because we wanted to keep 1.5 from the last tooth as a distance and 3 millimeter between the implants. We chose to use a 3 millimeter, 3.2 actually, but the body is 3. The neck is 3.2 millimeter. Implant was placed, and this is the position. This is the bone graft. As you can see, the bone graft is done. The area sutured. Okay, and we can know how long it took us, so we can kind of keep in mind the dryness of the area, because if we started at 154 and we finished at 240, it's within. We try to keep it in 45 minutes as much as possible, because that's the minimum amount of postoperative trauma. I'm not discussing the procedure now. I just want you to pay attention to, because of the concept of predicting everything is documented and we are following the protocol, when we come to the time that we want to decide on the solving this problem, which is not a small issue. This came last Wednesday to me. This is not an easy solution, but because we are following a protocol, it becomes suddenly easy. This is a time for uncovery. As you can see, one of the implants is 66, which is ready for uncovery. The second one is 44, which is not ready for uncovery. So either we have to postpone the case, check the vitamin D level, place a healing abutment out of occlusion and wait, or we have to make something called progressive loading, which again, you will receive a link for the ones who are part of the program to see what is progressive loading by Carl Misch. So we are doing the uncovery, and we are deciding that the occlusion, these implants cannot be loaded immediately. The impression is taken for progressive loading technique, and that's the. Now slowly your eyes will be, you'll see what is. Slowly you will understand that what went wrong, why we have these problems. Okay, these are the screw retained crowns that we will place for this patient. And okay, I think you are able to see the problem. Okay, there are two issues are very important here that you can easily identify. One is there is a frenal attachment here, and one, that depression, that means the bone graft did not take, and that means that if there is no support for the soft tissue, eventually we know the bone graft is going to go. The non-touching part is part of our protocol for progressive loading, but this part is one issue. The second issue was the patient was in crossbite in the previous photograph. We tried to correct the crossbite. So now, because of our knowledge of what did we do wrong is become apparent. I'll show you also the radiographs, so it's easier for you to understand the steps clearly. So this is how the patient presented. This is the expansion, placement of the implant, avoiding the sinus. This is the implant in place. As you can see, the implant is placed at the bone level. And we are doing other implants, but still the bone is kept at the same level. As restoration is taking place, the bone resorption is happening in between. But because of the cementum, the bone is still there on the other two sides. Only in between, the bone is going away. The restoration is showing that. still is there. So the bone is not consistently staying in that area, and that was not paid attention to. So if you can see, the restoration is removed to clean the area and to do some augmentation. So now let us go back to the chief complaint, or the complication. Look at the case and look at the position of the implant. Now, the reason why we have all this information is because we did not miss the steps. We took photographs at the time of diagnosis. That was a good thing. And that's why we can discuss this case, and we can see that depression was there from day one, and we didn't pay attention to that depression. The radiography was done, all the steps, so we know the bone level, and we can see that the issue is not only the bone. The part which we missed was during the uncovery, nobody noticed the depression of the soft tissue and a thin biotype, and soft tissue augmentation was not done. And because that was not done, there was no support for the bone to feel enough nourishment, even if we did bone grafting. So the bone grafting, without sufficient soft tissue coverage, we could have easily at this stage, when I say power of when, at the uncovery stage, soft tissue graft should have been done. We know how to do a soft tissue graft. So this is what is identified now to be the problem. At the time of impression, occlusion was not very much paid attention to. That if he is in a crossbite and you're putting the restoration in a class 1, you are causing a lot of stress on the 3.2 millimeter diameter implant. So that implant, after we did the proper crown, of course we changed those 2 crowns after the ISQ value became higher. Because of that, the screw broke. So the next crown which that tooth is going to have will be, we have to pay attention to the contacts on lateral excursions in a way that it will not break. So by notifying these 2 things, now we know the solution for such a complicated case, what it is going to be. And we have the steps for any procedure. You want guided bone regeneration, we know all the steps. And if something we miss, we can go back and check the photographs, check the steps that we did, and see why this complications have happened. And this applies to any procedure. If you're doing free gingival graft, if we are doing anything, we know the steps and we stick to the steps and we identify what went wrong and we go and correct. So for us to solve this problem is we will remove the broken screw by using a reverse torque kits that is available, and then we will let me go back to the screen. So the first step is to remove the broken screw using a reverse torque kits that is available. And obviously the reason why this went in when the colleague tried to remove it was the first thing we normally suggest is to use a scaler and keep it there for sometimes 7, 8 minutes on the center of the broken screw and go anti-clockwise. Move your hand anti-clockwise without damaging the walls. Probably that part, the anti-clockwise, was not done and the scaler was actually pushing it in. Anyway, we can remove this screw by using the, as I said, the kit is available. After that, we go to the pallet We use a pedicle flap, bringing the soft tissue all the way to the buccal. And as you saw, the frenal attachment was too high. That has to be corrected. And that is the solution for such a complicated scenario. In just a matter of 5 minutes, we were able to solve the problem. Of course, we have to see how the patient will um, respond to that after 3 months of soft tissue healing. But in my mind, I have a plan and I have steps to follow that plan to solve that problem. And I have the equipment to do that procedure. I hope this session was beneficial and we did a real case which actually came, and we trying to show the importance of following the steps, and we are trying to guide you how the process of solving complications can help you in identifying the solution and predicting the problem earlier. Thank you very much.
Thank you, Dr. Souheil. Thank you once again for the lovely session. Friends, if you have any questions, please feel free to post them in the Q&A box that you can see below of your screen. There's a Q&A box. You can post any of your questions related to this very webinar. Our speaker, Dr. Souheil, would love to answer them all. Thank you, Dr. Souheil. I request you to kindly stop your screen share for a moment. Friends, we'll be running a poll shortly. I request you to kindly answer the poll. And once again, in the meanwhile, while you're answering the poll, I'd request you to kindly note down all your questions in the Q&A box. Friends, it's a humble request. While you're noting down your questions, I request you to kindly use full forms of whatever that you wish to ask so that it becomes easier for us to figure them out and to answer them quickly. Once again, it's a gentle request. If you can answer the poll, it would really be nice. Thank you. All right, yes. In the meanwhile, for the ones who've already thanked us that you liked the webinar, we would like to thank you for your comment. And for the ones who feel they really found this webinar very informative, they can also post their comments. We would also know how you felt about the webinar, if you felt it was a very knowledgeable webinar, if you found it very interesting, if you learned something from this webinar. For giving your time for today, we would like to know from you. You can post the same in the chat box. Thank you, friends. Thank you for answering to the poll. I'd like to give you a short brief. Well, once again, greetings from team DentistChannel.Online. Hi friends, greetings from Team DentistChannel.Online. We're sure you've already subscribed to us so that you stay in touch with us. For the ones who've not done it yet, I request you to kindly subscribe to DentistChannel.Online's social media handle so that you can stay in touch with us, so that you get to know about what's gonna happen next when it comes to webinars, sessions, courses, etc. Please do subscribe to DentistChannel.Online. Dr. Souheil's already mentioned about the next part. Friends, Dr. Souheil's mentioned about the next part, which is a 52-session course. We'd be running this course on the same topic, complications and its solutions in implant dentistry. For the ones who are seriously interested to learn from this program, to benefit from the program, you can get in touch with us. This is our WhatsApp number. If you wish to participate, if you wish to know more about the program, you can surely get in touch with us. Our executives would love to answer to all your queries with regards to this very course. This course, the actual classroom program would be starting shortly. I request you to kindly register for the course. It's a 52-session course. Like today, it is going to take place every week, one session a week for 52 sessions in total. You can get in touch with us if you wish to know more about the course. Here's a sample certificate that we will be giving you after the completion. The course is accredited with CMERs from Dental Continuing Education and the Federal Dental Association from Germany. I'm sure you would definitely want to register for the course. If you're interested, like I've mentioned, you can WhatsApp us on the below mentioned WhatsApp number. Any certificate for attending this webinar would be given to our Prime members. For that, for the ones who have our number, should message us their names and the name of the course on the WhatsApp number that you already have. And for the ones who are not Prime members, I request you to kindly become a Prime member so that you can avail exclusive benefits on a lot of events that would be taking place all throughout the year. Here's about the next session. The next session is going to take place tomorrow, and that's on the topic management of medical emergencies in dentistry. If you're interested to register for this webinar, which is going to take place tomorrow at 11 a.m. Indian Standard Time, I request you to register for the webinar by clicking on the link which you will get in the chat box below. Thank you. That's it from my side. And we now start with the question and answer session. The first question is from Dr. Rupanjan. So, how to deal with abnormal frenal attachment as seen in this case?
You just have to cut it away and make sure that you suture it in a way that you don't remove, I mean, you don't reduce the vestibule. You want to maintain the vestibule depth. So you just follow, there is enough surgical technique. One is a Z technique, one is there's enough techniques. You just have to make sure to test if your technique worked or not, you basically pull the lip at the time of when you sutured, or even if you use laser without suture, that's your call. You can use different techniques. When you pull the lip, you should not see that the buccal soft tissue around the implant is actually getting pulled. Once you get that, you're done. You just maintain it for at least 21 days to make sure it doesn't grow back and close all your hard work. And that's it. After 21 days, once the epithelium is formed, it's not going to come back.
Thank you, sir. Next question from Dr. Qureshi. What all are the procedures to remove the broken screw?
Broken screw is itself, once we come back again to the class, we will talk about broken things, broken implant, broken screw. Is it a healing abutment screw? Is it an abutment screw? Is it all these multi-unit abutment screws are even smaller. So we have a whole session on broken things. But to answer it very quickly, generally, there is a reverse torque instrument with a small drill at the top, and it has a ring. You place the ring inside the implant, and you take that screw in a reverse torque, because you don't want to damage the wall of the internal part of the implant. So you place that ring with a holder, it comes with a holder, and you go with reverse torque, and you keep trying to luxate that screw in a reverse mode. Generally, it comes out. It should come out. There is no reason why it shouldn't come out. Yeah.
Thank you, sir. Next question from Dr. Shahzada. If we are doing bone graft in the buccal aspect of any defect, what type of bone is going to form? Whether it will be cortical bone or cancellous bone?
Definitely, it's not cortical bone. We do not have. The only time that I'm still working on this study, I haven't finished it yet because it takes time for this kind of studies to actually give you the final perfect answer is when you are using amniotic membrane from from the placenta of a pregnant woman. Now they're available. Those membranes are available. We found in our cases, when we use that kind of a membrane, we get a thicker surface on the augmented area. So otherwise, normally it's kind of a cancellous bone that we get. So as a general rule, you never get that hard cortical bone that you get on an anterior mandible. Never. It's generally a cancellous kind of a result.
Thank you, sir. Next question from Dr. Gaurav. If we are planning to place an implant in region 27 and CBCT shows 5 millimeter height from crest to maxillary sinus and there is retention cyst present in maxillary sinus, what will be the protocol to treat this? Whether we remove cyst first and then place the implant with sinus lift after 6 months, or can we lift the membrane with cyst to place implant with graft if possible? Kindly guide me.
It's a good point. We normally don't try to remove this because removing the cyst, you have to rip the entire Schneiderian membrane. You make a window in the sinus, not under the sinus. And you have to rip everything apart. It's very painful. It takes time to heal. And the patients will be in, like they need to rest for a while. And you need to wait 3 months, up to 6 months for that new Schneiderian membrane to mature. I know most of you believe that in 21 days epithelium is formed. There is a difference between formation and maturation. So if you want that membrane to mature, so when you get in again to lift it, it doesn't tear or crumble on you, you need to wait for the membrane to mature. So that's why you have to wait if you want to remove the cyst for this procedure. However, if the patient is not having any symptoms of discomfort or discharge or cold, that means it's a benign cyst. I mean, it's quiet. It's not doing anything. Probably the patient has it for many years. Then you can lift it with being careful and place your PRF underneath, or you can place your bone underneath. Depends on how much you want to place your implant. As an average, 10 to 11 millimeter implant should suffice for that area. Of course, if you are a bicon family, 6 millimeter, 5 millimeter is enough to do that procedure. So you don't need to lift as much. I hope I answered.
Thank you, sir. Dear participants, any more questions before we wind up the session? If you have any questions, please feel free to post them in the Q&A box. All right, that brings us to the end of the session. Thank you, Dr. Souheil, for your lovely presentation, for your time, and for everything. Dear participants, thank you for registering for this webinar. For the ones who are interested to attend the 52 session course, do get in touch with us, and I'm sure you would be benefiting while attending the 52 session course. The course classroom program would be starting shortly. I request you to kindly register for the course. Thank you, and may you all have a good day.